Diagnosing neurological problems requires us to, look at the complete picture.
Right,
And that's what this deep dive is all about today.
right.
Trying to understand the fundamental way neurologists approach these often really complex situations.
We're essentially getting a behind-the-scenes look at how the experts think.
That's a good way to put it.
We've got some fascinating material to explore as we delve into the core principles that guide neurologists in their work. And at the heart of it, we're going to focus on two equally vital elements.
The patient's narrative, their history, and the neurological examination itself.
And they're both crucial. Right.
Oh, absolutely. And it's so important to see these not as separate steps, but as deeply connected. Each one informs the other as we try to, figure out what's going on.
Now, what really stood out in our sources is this unique emphasis in neurology on localization and phenomenology. Okay, let's unpack this a bit.
Sure.
Localization, simply put, is the process of figuring out where in the incredibly complex nervous system the problem is actually coming from.
Right. Where's the issue located?
Think about a common symptom, like, say, a weak hand.
Okay.
What's fascinating here is that a weak hand can have so many different roots. As our sources highlight, the issue could be in the muscles of the hand itself.
Or the nerves running down the arm.
Or that network of nerves in the shoulder, the brachial plexus. Or even the spinal cord in the neck.
Or higher up, right.
Yeah.
Somewhere in the brain.
Exactly. It's like a light switch that isn't working. The problem could be the switch itself, the wiring, or even the power source, the fuse box.
That's a great analogy. And that's where the neurological exam comes in. It's specifically designed to help pinpoint that offending lesion, the precise location that's causing the weakness.
Right. Trying to find the faulty wiring, basically.
And then we have phenomenology.
Ah, yes, phenomenology. This is about carefully recognizing and categorizing the different types of neurological signs and symptoms we observe.
So what does it look like?
Exactly. Take movements, for example. A neurologist needs to be able to distinguish between a tremor, that rhythmic shaking, like someone's hand gently moving back and forth,
Okay.
and a stereotypy, which is another type of repetitive movement, but maybe more complex or purposeful looking.
I see.
Or telling the difference between a tick, a sudden brief jerk.
Right. Myoclonus, another kind of brief shock-like jerk, and chorea, which involves more sort of fluid, dance-like involuntary movements.
Wow. It's like having a really trained eye and ear for the specific language of the nervous system.
It really is. Our source even includes a figure 1.1, which serves as a kind of roadmap for this whole diagnostic journey.
Oh, okay.
It illustrates how neurologists progress from gathering all the initial information, the history, the observations, to ultimately understanding the anatomical location of the problem and the underlying nature of the disease process itself.
Got it. So with that overview, let's really dive into that first crucial step, the neurological interview.
Absolutely. The interview is where we begin to piece together the patient's story. And our sources really stress that approaching this with empathy is just paramount.
That makes sense. People must be anxious.
Extremely. Patients are often understandably anxious when facing potential neurological issues, worried about conditions that might worsen over time or even be life-threatening.
Right. So setting the right tone from the outset is vital. This includes, introducing yourself clearly, maybe exchanging a few polite words before diving straight into the medical questions.
Yeah, building that rapport.
The sources suggest some helpful icebreakers, like asking about handedness, or for children, maybe about school or their favorite activities. It just helps put people at ease.
Definitely. And establishing this initial rapport makes it easier when you move on to those crucial opening questions. How can I help you today? Or what brings you in to see me? These encourage the patient to start sharing their history in their own way. And for follow-up visits, maybe more personal questions like, how have you been feeling? Can be a great way to begin.
I also found it interesting how important it is to understand the patient's expectations. The source even suggests asking, what can I do to help? Right near the beginning.
Yeah, what are they hoping for?
It highlights that patients come with a whole range of hopes and fears. Some are looking for confirmation of a diagnosis they suspect.
Others are desperately hoping to rule out something serious.
And some, maybe, just want to feel heard after perhaps feeling dismissed in previous consultations.
Understanding those underlying expectations can really shape how the whole consultation unfolds.
Right.
Now, after these initial steps, we get to the chief complaint. Our source describes this as the usual starting point of the diagnostic process.
This is the main reason they came in.
Pretty much. It's what focuses our attention and provides those initial critical clues about where the problem might be located in the nervous system, the anatomy, and what the underlying cause or etiology could be.
Exactly. The example provided in our material is a patient who presents with headache, clumsiness, and double vision.
Right. And the source points out that this combination immediately raises concern for a potential tumor in the posterior fossa.
That's the back part of the brain.
Correct, which can affect the cerebellum responsible for coordination and the brainstem, which controls many basic functions. So those symptoms point you towards a specific area.
Got it.
And then, digging deeper, our source emphasizes the critical importance of the history of the present illness.
Okay, this is where the details come in.
This is where we really explore the details of each symptom.
Yeah.
And localization, figuring out where the problem originates, remains a key focus throughout this whole process.
And it's not just what the symptoms are, but also their temporal severity profile.
Yeah.
How they've developed over time and how severe they've become.
Yes, the timing is crucial. The source gives a great example. A gradual onset of headache and weakness on one side of the body, maybe over weeks or months,
Slow onset.
might suggest a slow-growing mass in the brain, like a tumor.
Okay.
Whereas, as the source points out, those exact same symptoms, headache and one-sided weakness, if they appear suddenly, like within minutes or even seconds, and they're at their maximum intensity right from the start, that strongly suggests a hemorrhage, bleeding in the brain.
Wow.
So even with seemingly identical symptoms at that time you see the patient, the way they developed over time points to very different potential causes.
This really highlights the detective work involved. But getting a reliable history isn't always straightforward, is it?
Not at all.
The source discusses the need for direct questioning to clarify symptoms, but also cautions against sort of leading the patient with our own assumptions.
That's a very fine line to walk. People often want to please authority figures, even if it means giving an answer that isn't entirely accurate.
Yeah, you don't want to put words in their mouth.
Exactly. And the reliability of the history also depends on various factors, as our source notes. The patient's understanding, their memory, their language abilities.
Their background?
Yeah, their educational and social background, and even whether there might be any secondary gain issues at play, meaning could they benefit in some way from being sick?
The source also touches on when a clinician might suspect something like a somatoform or psychogenic disorder.
Right, when the symptoms might not have a clear physical basis.
This could be if symptoms begin very suddenly, particularly after a stressful or traumatic event, maybe?
That can be a clue. Or if the clinical features don't quite align with any known organic physical disorder. Or if multiple different body systems seem to be affected without a clear underlying medical explanation.
Okay.
And it's important to remember, as our source points out, that diagnosing a psychogenic disorder isn't just about ruling out physical causes. There often need to be positive indicators as well. It's a diagnosis in its own right.
And in these kinds of situations, and also for conditions like seizures or dementia, getting information from someone else,
Yes.
an observer, that can be incredibly valuable.
Oh, absolutely. A witness account of a seizure, for example, is often much more helpful than the patient's own description, because they might not remember it clearly.
And taking a history from children presents its own unique set of challenges, doesn't it?
Definitely. Shyness, a different perception of time, a limited vocabulary, it all plays a role.
Our source rightly mentions that in pediatrics, the history is often a combination of what the child says and what the parent says.
You have to weave those accounts together.
Communication can be a real obstacle in any patient encounter, actually.
For sure.
As our source highlights, patients and physicians can use the same words but have very different meanings in mind.
That happens all the time. For example, a patient saying their arm is numb might actually mean it's paralyzed, unable to move.
Oh, wow. Not just lacking sensation.
Right. Or dizziness, that could mean lightheadedness, confusion, weakness, not necessarily the spinning sensation of vertigo that a doctor might typically think of.
And even descriptions of vision like blurred could turn out to be double vision when you ask more specific questions.
Exactly. The source provides a whole list of these potential miscommunications, blackouts, pounding headaches, emphasizing the need to really clarify what the patient means by their words. Don't assume.
So the neurologist has to be meticulous, really understanding the precise nature of each symptom. When it started, how long it lasts, how it has progressed over time, and how different symptoms relate to each other.
Are they getting better, worse, staying the same? What makes them feel better? What makes them worse? What has no effect?
And for infants and young children, the timing of reaching developmental milestones, like when they first started walking or talking, becomes another crucial piece of information.
Yes, that developmental context is key.
The source provides a fantastic example here. A 28-year-old woman who experiences recurrent headaches around the time of her menstrual cycle.
Okay.
The fact that the pain is sometimes only on one side of her head and is associated with things like flashing lights, nausea, and vomiting strongly suggests migraine.
A classic migraine pattern.
But then, the source contrasts that with the same patient experiencing a progressively worsening headache upon waking up, along with new seizures and developing weakness on one side of her body.
Completely different picture.
Totally. This points towards an intracranial space-occupying lesion, something taking up space inside the skull like a tumor.
It really shows how both the presence and the absence of certain features can be diagnostically critical.
Absolutely. The example of foot numbness is also really telling. Numbness in the feet alone might suggest a problem with the peripheral nerves in the legs.
Peripheral neuropathy, maybe.
Yeah. But if it's accompanied by back pain and a loss of bowel or bladder control.
Whoa, red flag.
Exactly. That immediately raises suspicion for a problem in the spinal cord or the cauda equina. That bundle of nerves at the end of the spinal cord changes the whole game.
Big time. Now, it's quite common for patients to come in with folders full of previous test results and reports.
Oh yeah, the binder of tests.
Right. And while this information is valuable, our source wisely cautions against just blindly accepting previous diagnoses without question.
Good point. Things change, or maybe the first doctor didn't have all the info.
Exactly. Prior doctors could have had incomplete information or reached a different conclusion based on the knowledge available at that time. The neurologist needs to take a fresh history, conduct their own assessment.
But still use the old data.
Oh, yes. While, of course, integrating those objective data points like dates and actual test results into the patient's overall narrative is part of the story.
And finally, in this part of the interview, the source highlights the importance of understanding how the patient or their caregivers have responded to the symptoms.
That's interesting. How so?
Well, did they perhaps ignore something that turned out to be serious, like a new, really severe headache? Or maybe did they become overly concerned about something relatively minor?
Ah, I see. Those responses can sometimes offer additional insights into the patient's perception or maybe even the nature of the symptoms themselves.
Exactly. Okay, so after we've gathered this really detailed story from the patient, what comes next in the diagnostic process?
The next vital step, as our sources outline, is reviewing patient-specific background information. This helps us build a more comprehensive context around the neurological issues the patient is presenting with.
That makes perfect sense. It's about looking beyond just the immediate symptoms and understanding the individual's overall health and life experiences.
Right. The source mentions several key areas here. Their past medical and surgical history,
Okay.
any current medications they're taking, and any allergies they have.
Standard stuff.
A review of symptoms in other non-neurological body systems, their personal history, including occupation and social situation, substance use.
And the family medical history, too.
And the family history. Absolutely.
And while in an outpatient setting, patients might fill out questionnaires covering much of this information beforehand to save time.
Which is helpful.
Our source emphasizes that often we need to delve into more specific details. Things like exposure to chemicals at home or work.
Past use of alcohol, tobacco, or other substances.
Any big stressors in their life, like relationship changes, loss of a loved one, job loss.
All relevant. The source also raises important points about looking for potential signs of abuse or neglect, and the need for a sensitive and careful sexual history when it's relevant to the presenting problem.
And for children and adolescents, the source stresses the importance of sometimes speaking with them privately.
Yes, to get more accurate information about sensitive topics like sexual activity or substance use, which they might not share in front of parents.
Now let's talk about the review of systems. Our source explains that this involves asking specific questions about different aspects of nervous system function that might not have come up naturally,
Things you might have missed.
as well as a general overview of the health of all other organ systems in the body.
Right. So specifically regarding neurological function, the neurologist would ask about things like changes in their thinking or memory cognition.
Personality shifts, mood changes.
Yep. Any experiences of hallucinations, seizures, or other alterations in consciousness, dizziness upon standing up,
Headaches, vision, hearing problems.
difficulties with speech and language, trouble swallowing, coordination issues, slowness of movement, any involuntary movements,
Changes in strength or sensation, pain.
problems with their balance or the way they walk their gait,
Mm.
and even any changes in their bowel, bladder, or sexual functions. Pretty thorough list.
It is.
And as our source points out, a positive response to any of these questions can be very informative in narrowing down the possible diagnoses.
Got an example.
Yeah, to give a great one. If someone complaining of poor coordination and weakness on one side of their body also mentions hearing loss in one ear.
Hmm.
That should immediately raise suspicion for an acoustic neuroma, a benign tumor affecting the nerve connecting the inner ear to the brain. It connects the dots.
Ah, okay. Another example given is headaches in a patient who also reports weakness in both legs.
Right. That might suggest a meningioma, a type of tumor growing along the membranes surrounding the brain and spinal cord, perhaps in the midline, rather than a problem just within the spinal cord itself.
And our source reminds us that in children, and sometimes even in adults whose illness began in childhood, understanding their developmental history when they hit those key milestones is really important.
Crucial context. And it's also vital that the review of systems extends beyond just the nervous system.
Because everything's connected.
Exactly. As our source emphasizes, neurological function can be significantly impacted by problems in other organ systems, like the liver, kidneys, GI tract, heart, blood vessels.
Makes sense. Our source mentions that involvement of multiple organ systems is a key feature in several neurological disorders like vasculitis,
Inflammation of blood vessels.
sarcoidosis,
Those inflammatory cell clusters.
mitochondrial disorders affecting energy production.
And storage diseases, where the body can't break down certain substances properly, they can all have neurological effects.
Okay, moving on to the history of previous illnesses. Our source highlights how past medical and surgical events can directly relate to current neurological complaints.
Right, like someone with a history of lung cancer who now experiences seizures and worsening headaches.
You'd worry about brain metastasis, cancer spreading to the brain.
Exactly. Or chronic low back pain in a patient who starts complaining of leg weakness might point towards a herniated disc pressing on a nerve.
Our source reminds us that this part of the history should include details of all surgeries, significant injuries like head trauma, hospitalizations, any medical conditions they've been diagnosed with, and medications they've taken in the past.
And for pediatric patients, information about the mother's pregnancy and the child's birth history are also important parts of that past history.
Are there specific things in the past history that should really wave a red flag?
Definitely. Our source mentions gastric surgery potentially leading to vitamin B12 deficiency, which can cause neurological problems.
Okay.
Sarcoidosis, causing a wide range of neurological issues. Disorders of the liver, kidneys, small bowel, all associated with various neurological complications.
And cancer history.
Absolutely. A history of any systemic malignancy should always prompt consideration of neurological spread or other related syndromes. And it's a good reminder that patients may not always remember past medical issues accurately.
Right, you might need to check old records.
Sometimes, yeah.
Medications, as our source points out, are another very common cause of neurological disturbances.
Huge category.
And this includes not just prescription drugs like chemotherapy, certain antibiotics like isoniazid, ethambutol, lithium, neuroleptics.
But also things people might not think of as drugs.
Exactly.
Yeah.
Over-the-counter pain relievers, herbal supplements. You have to ask specifically about everything they take.
Essential. The family history is also incredibly important, especially considering that many neurological disorders have a hereditary component.
So a history of similar illnesses in family members, or even if the patient's parents are related, like cousins, that can be a significant diagnostic clue.
Definitely. However, our source cautions that the way a genetic mutation manifests its expression can vary greatly between family members.
Meaning?
Well, not just in terms of severity, but also which parts of the body are affected. One person might have weakness, another just cramps from the same underlying gene change.
And reported diagnoses within families might not always be accurate either.
True. Our source gives the example of arthritis in older relatives, potentially masking what was actually a dominant form of muscular dystrophy.
Ah, okay.
Also, conditions like epilepsy or Huntington's disease might be considered family secrets due to stigma. So it's important not to just accept a patient's statement that there's no relevant family history at face value.
Dig a little deeper.
Yeah, maybe ask more specific questions. Our source suggests getting information from multiple generations if possible, and even examining at-risk relatives when appropriate.
And sometimes family members might mistakenly attribute symptoms to, like, normal aging or other conditions.
Especially with things like essential tremor, that common movement disorder. People might just say, oh, grandma always had shaky hands.
Right. Our source specifies that for all first and second degree relatives, we ideally want to know their current age, or age at death, the cause of death, and any significant neurological or systemic diseases they had.
That detailed pedigree helps.
Finally, the social history provides crucial context. changes in family status, employment history. Has someone lost their job due to cognitive decline, for example?
The impact of their neurological issues on daily activities and safety, like driving.
Any potential exposure to toxins through their job or hobbies?
For children, it's important to ask about their social interactions, any experiences with bullying.
Travel history, relevant for infections.
Even hobbies. Working with solvents could indicate toxin exposure. And the level and type of exercise they engage in can give clues about overall fitness and potential exposures like Lyme disease from outdoor activities.
Wow, it's a lot to cover. So after gathering all this detailed historical information, the neurologist moves on to the physical examination with a particular focus on the neurological exam.
That's right. And our source makes a key point. The neurological examination actually begins during the interview itself.
How so?
Through careful observation of the patient. We pay attention to things like their facial expressions, their speech patterns, any involuntary movements we might notice while they're just sitting there talking.
It's like the neurologist is constantly gathering data, even before the formal hands-on exam starts.
Pretty much. Our source then contrasts the very comprehensive neurological examination that doctors in training learn.
The really long one.
Yeah, the one that covers everything meticulously.
Right.
With the more focused approach that experienced neurologists often take. They tailor the exam based on the clues they've gathered from the history, while still performing a basic screening exam.
So they don't necessarily test everything every time.
Not always in exhaustive detail. The goal here, as our source emphasizes, is to either confirm, refute, or maybe modify the initial ideas about where the problem might be located and what might be causing it, the hypotheses developed from the history.
And it's important to remember that both the presence and the absence of abnormalities during the neurological exam are significant.
Critically important. Our source gives a helpful example of a patient whose symptoms suggest weakness on the left side of their body, a left hemiparesis.
Okay.
In that scenario, the neurologist would specifically look for other associated findings. For example, they might check for a left homonymous hemianopia.
That's the vision loss in the left field of both eyes.
Correct. And whether the blink or smile is weaker on the left side of the face. They'd also test for impaired rapid movements in the left arm and leg.
Increased reflexes on the left.
Increased reflexes on the left, an absent abdominal reflex on the left, and extensor plantar response, the Babinski sign on the left foot.
Where the big toe goes up instead of down.
Exactly.
And our source points out that the specific combination of which of these signs are present or absent can help determine whether that left hemiparesis originates from a lesion in the right cerebral cortex.
The outer layer of the brain.
Or maybe in the left cervical spinal cord in the neck. Different patterns point to different locations.
Precisely. The screening neurological examination, as outlined in our source, is designed to be a relatively quick evaluation of key areas. Mental status.
Alertness, thinking.
The 12 cranial nerves, vision, eye movements, facial sensation and movement, hearing, swallowing, etc.
The motor system.
Strength, muscle tone, any involuntary movements, posture.
Coordination.
Gait and balance, how they walk.
Reflexes, sensation.
Exactly. It hits the major domains.
And our source mentions an interesting point about the order of testing. Sometimes complex functions first.
Yes, more complex functions are often assessed first, because if those are performed normally, it might not be necessary to go into very detailed testing of individual components.
Like what?
Well, for example, someone who can walk heel to toe smoothly, tandem gait, likely doesn't have a significant problem with their cerebellum or their proprioception, their sense of body position.
Okay, so you might not need super detailed cerebellar tests.
Maybe not. Similarly, if a patient can easily do a push-up, rise from the floor without using their hands, and walk on their toes and heels, you can generally assume their individual muscle groups in their arms and legs have normal strength.
Functional strength tests.
Right. Our source also mentions the simple arm extension test, holding arms straight out, palms up, eyes open.
What does that show?
It allows you to assess their strength. Does one arm drift down? Their posture, and look for any involuntary movements or tremor. Simple but informative.
However, our source also cautions that this screening exam might miss certain important neurological abnormalities if you're not specifically looking for them.
True, it's a screen, not exhaustive.
For instance, a bitemporal visual field defect affecting the outer half of vision in both eyes might not be detected if you test both eyes together.
You have to test each eye individually for that.
Similarly, A problem in the parietal lobe of the brain, affecting spatial awareness and other higher-level functions, might go unnoticed unless you specifically assess those abilities.
Like testing for neglect or constructional apraxia.
One of the ongoing challenges in the neurological exam, as our source points out, is distinguishing between what's just a normal variation from person to person and what's actually a sign of a problem.
That really comes down to experience. Everyone has some degree of asymmetry, and what might be considered normal in an older individual might be a cause for concern in a young adult.
Like reflexes changing with age.
Exactly. For example, a diminished or absent ankle reflex and a reduced sense of vibration in the big toe are relatively common findings in people over, say, 70. Doesn't necessarily mean disease.
The experienced neurologist, our source says, understands this normal range of variation.
Whereas someone earlier in their training might be more likely to note minor, isolated findings like a slight deviation in the tongue or uvula, or small differences in reflexes or sensation between sides.
These are sometimes called soft signs.
Right. And our source explains that these soft signs might be taken into account if they fit with the overall pattern of findings from the history and the rest of the exam, but otherwise they might not be clinically significant on their own.
But when a definite abnormality, a hard sign, is identified, the next step is to look for other findings that are often associated with it.
Okay, so you find one thing, you look for his friends.
Basically. For example, if someone has ataxia or incoordination in one of their limbs, that could be due to a problem in the corticospinal tract, motor control, a sensory deficit, position sense, or a lesion in the cerebellum.
3 possibilities.
Right. If the incoordination is specifically due to a cerebellar issue, you'd expect to see other cerebellar signs.
Like difficulty with finger-to-nose testing, heel to shin.
Exactly. Clumsiness with rapid alternating movements of the hands is diadacokinesia and often involuntary eye movements called nystagmus. And if those other cerebellar signs aren't present, then you'd need to examine other functions like their joint position sense, limb strength, and reflexes to determine if the incoordination has a different origin, like sensory ataxia.
Got it. So at the end of the neurological exam, the findings are categorized as either clearly abnormal hard signs or potentially abnormal soft signs.
Our source reiterates that the hard signs, combined with the patient's history, are what help the neurologist develop a hypothesis about the anatomical location of the problem, or at least the specific nerve pathways involved.
And the soft signs.
They can then either support or maybe contradict that initial conclusion. But the primary purpose of the neurological exam is really to reveal functional disturbances that help pinpoint where the abnormality is located in the nervous system. Localization.
Our source also notes an important limitation. The standard neurological exam isn't always the best way to track how a disease progresses over time or how someone is responding to treatment.
Why not?
It's often not sensitive enough to pick up subtle changes. For that, more specialized quantitative functional tests and rating scales are often needed.
Okay, that makes sense for monitoring. Now, moving beyond the focused neurological exam, our sources emphasize the importance of a general physical examination. Why is that so crucial in neurology?
Because, as our source clearly states, the nervous system is frequently affected by general medical conditions. The brain doesn't live in isolation.
Right.
So a broader physical exam can uncover really important clues. For example, finding signs of an irregular heartbeat, like atrial fibrillation, or problems with the heart valves.
Could point to a source of blood clots causing a stroke?
Exactly. High blood pressure significantly increases the risk of all types of stroke. And finding signs of a previously undiagnosed cancer might raise suspicion for brain metastases or maybe paraneoplastic neurological syndromes.
Those are neurological problems caused by the body's response to the cancer, not the cancer itself spreading.
Correct. The immune system reacting in a way that damages the nervous system.
It really highlights how interconnected everything in the body is. Our source also mentions diseases like vasculitis and sarcoidosis, which can affect both the brain and other organs throughout the body simultaneously.
So that general physical exam provides absolutely vital context.
Okay.
Exactly. And with all this information gathered, the detailed history, the findings from both the neurological and general physical exams, the neurologist then proceeds to the critical stage of assessing the underlying cause of the patient's symptoms.
And the very first step in this assessment, according to our sources, is anatomical localization again.
Back to location.
It's about taking all the pieces of the puzzle and determining if the problem originates in the brain, the spinal cord, the peripheral nerves, the neuromuscular junctions where nerves talk to muscles, or the muscles themselves.
And also whether the disorder is focal, affecting just one specific area.
Multifocal, affecting several distinct areas.
Or systemic, affecting a broader system throughout the body.
Our source gives the example of motor neuron disease, or ALS, as a system disorder.
Right, where there's a progressive degeneration of specific types of nerve cells, the motor neurons, while other parts of the nervous system remain relatively okay.
Multiple system atrophy is another example of a system degeneration, affecting movement, coordination, autonomic functions.
Correct. A specific system is breaking down.
So how do neurologists translate the specific symptoms and signs they've observed into understanding which particular neurological structures might be involved? It sounds complex.
Well, it relies heavily on knowing your neuroanatomy, but our source provides some clear examples. Loss of pain and temperature sensation on one side of the body, but not the face.
Okay.
Typically points to a lesion in the contralateral spinothalamic tract in the upper cervical spinal cord. That pathway carries pain and temp from the opposite side below the neck.
Ah, okay. Specific pathway.
Or a specific combination like a left sixth nerve palsy trouble moving the left eye outwards along with weakness on the opposite side of the face and limbs.
A cross pattern.
Yes, that suggests a lesion in the pons, a specific part of the brainstem where those pathways cross over.
And a homonymous hemianopia, that vision loss in the same half field of both eyes.
That indicates a problem somewhere along the optic pathway behind where the optic nerves cross, maybe the optic tract, or the visual cortex in the brain.
It really comes back to that detailed knowledge of neuroanatomy that our source emphasized earlier. You have to know the map.
You absolutely do. And the neurological exam plays that crucial role in confirming this initial idea about the location.
Right. The source reiterates this with the example of someone complaining of tingling and numbness in their feet. Initially, you might suspect peripheral neuropathy.
A common cause.
But if the exam reveals increased reflexes in the arms and legs and a loss of vibration sensation way up below the collarbones...
That pattern doesn't fit peripheral neuropathy.
Right. It strongly suggests the problem is actually in the spinal cord. And you can then focus your thinking away from the many different causes of peripheral neuropathy.
Another example given. Someone with weakness in their left arm and leg, plus a left homonymous hemianopia.
Okay, weakness and vision loss on the same side.
That specific combination points to a lesion in the right side of the brain, not in the cervical spinal cord. The vision finding localizes it above the neck.
Now, once you have a likely location in mind, our source discusses the principle of parsimony, also known as Occam's razor. What does that mean here?
It's the idea of trying to find the simplest explanation that can account for all of the patient's symptoms and signs. Basically, strive to find a single lesion or a single underlying condition if you can.
Why is that important?
Because the list of possible causes, the differential diagnosis for a single problem, is often quite different from the list you'd consider for multiple separate issues occurring simultaneously. You think differently.
Our source gives an example of someone who develops vision loss on one side and weakness on the same side. It's more likely they have a single lesion in the opposite side of their brain.
From maybe a stroke or a tumor affecting both pathways.
Rather than two completely unrelated problems happening at the exact same time.
It's just statistically more probable. However, our source also cautions that sometimes you do have to consider the possibility of multiple lesions or multiple co-occurring conditions.
When would that happen?
Like in the example of someone who has vision loss just in one eye, maybe from optic neuritis, and upper motor neuron weakness affecting their limbs but sparing the lower face. That pattern suggests two distinct lesions.
Maybe pointing towards something like multiple sclerosis.
Exactly. MS is a classic example of a multifocal disease, and then there's the complexity of the brain's blood supply. Sometimes a single vascular event, like a blockage in the vertebral artery, can shower little clots, causing damage in multiple areas downstream.
So a deep understanding of neuroanatomy is absolutely essential to put all these pieces together. Our source even mentions the usefulness of diagrams, like cross-sections of the brainstem or spinal cord.
Visualizing those pathways really helps, and it's also important to be aware of so-called false localizing signs.
What are those? Signs that point to the wrong place.
Not exactly wrong. But our source clarifies that these are neurological findings that indicate a more widespread issue, like a significant shift of brain tissue within the skull, or abnormally increased intracranial pressure, even if the primary problem, like a tumor, is located elsewhere.
Ah, so it's an indirect effect.
Right. A classic example is a sixth cranial nerve palsied trouble moving the eye outwards that can be caused by increased pressure from a tumor located far away from that specific nerve. The pressure stretches the nerve.
Okay, so once you have a likely location or locations in mind, what's the next step in figuring out the why, the underlying cause?
That's when you start considering the pathophysiological mechanisms. What kind of disease process is actually happening?
Okay.
Our source provides a helpful list of these broad categories, which includes inflammatory processes, both infectious and autoimmune.
Vascular issues affecting blood flow.
Compressive or infiltrative problems like tumors or other growths pressing on things.
Degenerative or hereditary conditions.
Toxic, metabolic, or nutritional factors.
Mechanical issues like trauma.
And disorders that affect the pressure within the skull. It's a framework to think through the possibilities.
So it sounds like you systematically go through this list and consider which of these mechanisms are most likely to be responsible for the patient's symptoms and signs, given the anatomical location and their overall clinical picture, especially the timing.
Precisely. And once you've narrowed down the likely underlying mechanisms, that leads you to generating a differential diagnosis.
The list of suspects.
Exactly. A focused list of the possible diseases or conditions that could be causing the patient's neurological problems. Our source notes that experienced neurologists tend to prioritize the most likely causes based on their knowledge and pattern recognition.
While beginners might list everything.
Yeah, maybe create a broader, less focused list initially. It takes experience to weigh the probabilities.
And our source makes a really important point. Rare presentations of common diseases are actually more frequent than common presentations of rare diseases.
That's a crucial clinical pearl. Think common things first, even if they look a bit unusual.
But you still need to consider the rare stuff.
Oh, yes. Equally important is to include less likely, but serious and potentially treatable conditions in that differential diagnosis. You absolutely don't want to overlook something treatable that could have significant consequences if missed.
So a good differential includes both the most probable and the most critical can't miss possibilities.
That's the goal.
Our source also reminds us to keep in mind the temporal features, how the symptoms progressed, and the types of pathological processes known to affect the specific area you suspect is involved.
Right. For example, a sudden onset of paralysis, a hemiplegia, in the context of a lesion in the internal capsule area of the brain strongly suggests a stroke, a vascular event.
Whereas a more gradual, progressive weakness in the same area might point towards a tumor growing there.
Exactly. And if someone has signs of problems in multiple different areas of the nervous system that have appeared and then resolved over time, relapsing, remitting.
You might think of MS or maybe multiple small strokes.
Right. If the symptoms have appeared more recently and are steadily worsening, then the possibility of metastatic disease, cancer spread, might come higher up the list. The time course is key.
The principle of parsimony, Occam's razor, comes back into play here too, doesn't it? When you're creating that differential diagnosis.
You try to find a single underlying condition that can explain as many of the patient's findings as possible.
Our source gives the example of someone with a progressive problem affecting their spinal cord who suddenly develops aphasia, a language difficulty.
While it's possible they have two unrelated conditions hitting at once.
It's more likely there's a single underlying cause, perhaps a cancer that has spread to both the spinal cord and the brain, causing both problems. Try to unify.
Exactly. However, our source also mentions Hickham's dictum as a counterpoint.
What's that?
It basically reminds us that sometimes patients can indeed have multiple unrelated disorders occurring at the same time. A patient can have as many diseases as they damn well please.
So don't get too locked into finding just one cause if the evidence points elsewhere.
Right. Be flexible. So the differential diagnosis often starts broadly, with categories like stroke, tumor, infection, inflammation.
And then you narrow it down within each category.
Yes. If you suspect an intracranial mass, you then think about the different types of brain tumors, gliomas, meningiomas, metastases, as well as non-cancerous causes like abscesses or granulomas.
Similarly, if you suspect a stroke, you'd consider whether it was caused by a hemorrhage, an embolism, a thrombosis, vessel spasm, or vasculitis.
And our source really emphasizes the importance of considering all possibilities, especially those that are treatable and might mimic more common but currently incurable neurological disorders like Alzheimer's disease or ALS.
You don't want to miss, say, vitamin B12 deficiency causing dementia-like symptoms because that's treatable.
Precisely. Or Lyme disease mimicking other neurological conditions. Always consider the treatable mimics.
Now, sometimes, even after a thorough history and a careful neurological examination, the diagnosis isn't completely clear. That's when further investigations become necessary, right?
Yeah. It's exactly. Ancillary testing. Our source acknowledges that in some straightforward cases, like classic presentations of Parkinson's disease, myasthenia gravis, or maybe typical MS based on clinical criteria alone,
A diagnosis might be possible based on the clinical picture.
it might be strongly suspected, yes.
Huh.
However, even in those situations, additional testing is often important for documenting the findings, ruling out other possibilities, and sometimes for prognosis or treatment planning.
And in many other cases, these tests are absolutely crucial for figuring out the underlying cause.
Definitely. Our source lists a range of potential investigations. Blood studies looking for infection, inflammation, metabolic issues, vitamin deficiencies,
Neurophysiological testing like EEGs for brain activity, EMGs for nerve and muscle function,
neuroimaging MRI and CT scans to visualize the brain and spinal cord structure.
organ biopsies sometimes.
Yes, like muscle or nerve biopsy if needed. Bacteriological and virological studies to identify specific infections, and increasingly genetic testing for inherited disorders.
MRI gives really detailed pictures of the brain, right?
It does. MRI uses strong magnetic fields and radio waves to create incredibly detailed images of soft tissues, like the brain and spinal cord. It often reveals subtle abnormalities that CT scans, which use X-rays, might miss, though CT is faster and better for acute bleeding or bone issues.
Okay. And our source mentions more detail on these tests in another chapter for those interested.
Right.
So we've discussed the history, the examination, figuring out the location, the possible causes, the tests. What happens once a diagnosis is made, or even while the diagnostic process is still underway?
That leads us to management. Our source briefly touches on this, reminding us that even when a neurological disease isn't currently curable, and sadly, many neurologists still focus heavily on alleviating the patient's symptoms.
Improving quality of life.
Absolutely. Reducing discomfort, maximizing function, and providing support for both the patient and their family in coping with the condition and its implications.
And our source concludes this section with a really insightful thought. Understanding the science behind neurological disease is essential.
Arriving at a diagnosis is a blend of that science and clinical experience.
And ultimately, managing the patient is truly an art.
I like that framing. Which leads perfectly into the final section, discussing the experienced neurologist's approach.
How does experience change things?
Our source emphasizes that neurological diagnostic skills are really refined through years of experience. Seeing a wide variety of cases teaches you what findings should and, just as importantly, should not be present in specific neurological conditions.
You build up mental models.
Exactly. Over time, neurologists develop these illness scripts, organized mental frameworks that allow them to quickly generate and test diagnostic hypotheses based on pattern recognition.
So it's about developing a strong sense of those patterns. Although there's no substitute for years of practice, the source suggests that those still learning can begin to understand the key clues that experienced neurologists use.
Yeah, it's not magic. It's about learning the heuristics, the shortcuts, the key differentiating features. It's not just memorizing lists of symptoms, but understanding how those symptoms cluster together to form recognizable patterns linked to specific neurological problems.
And for those who want to delve deeper into this, our source mentions that part 1 of the book it comes from covers the main symptoms and signs of neurological disease and how experienced neurologists approach these common presenting problems to reach a diagnosis.
And parts 2 and 3 then go into more detail about specific investigations and management strategies, as well as detailed information about individual neurological diseases themselves.
Okay, so to wrap up this deep dive into neurological diagnosis, we've explored the crucial initial step of obtaining a very detailed patient history,
covering everything from the chief complaint and the history of the present illness
to their past medical, social, and family history, and that thorough review of systems.
Right. This incredibly rich information then guides a focused neurological examination.
All based on those fundamental principles of localization, figuring out where in the nervous system the problem is.
And phenomenology, recognizing and categorizing the specific types of neurological signs and symptoms. What does it look like? Where is it happening?
From there, it's about considering the various underlying pathophysiological mechanisms that could be at play: inflammation, vascular, degenerative, etc.
And generating that comprehensive differential diagnosis, a prioritized list of possible causes.
Throughout this entire process, neurologists rely on the principle of parsimony Occam's razor, trying for the simplest explanation.
While also being careful to consider less common but critical can't-miss diagnoses, especially treatable ones, and being mindful of potential cognitive biases that can lead us astray.
And while advanced technology and all these investigations play a huge role in modern neurology,
They absolutely do.
it's clear that the foundational skills of carefully listening to the patient's story and conducting a thorough clinical examination remain absolutely paramount in unraveling those often complex neurological puzzles.
They really form the bedrock of accurate diagnosis. This entire process really underscores the intricate detective work that is at the heart of medicine, and particularly in neurology.
Yeah.
It's about carefully piecing together clues, forming initial hypotheses, and then systematically testing those hypotheses through the examination and, when necessary, further investigations.
And that leaves me with a final thought for you, the listener. Consider how this very systematic approach to diagnosis, moving from broad information gathering to formulating specific hypotheses and then testing them, might actually be applicable to problem solving in other completely different areas of your life.
Interesting idea.
Yeah, think about the detective work involved in understanding any complex system, whether it's a personal challenge you're facing, a tricky project at work, or even trying to understand a complex societal issue. That same structured thinking might just help.
Food for thought.
Definitely. Thanks for joining us for this deep dive.